And good morning. So I'm Bob Bollinger from Johns Hopkins, and we've got a great panel with us this morning, including to my left, Sally Stansfield from Deloitte, Twin from the USAID, Justin Kester from Medtronic, and Catherine Taylor from Notre Dame, and Margaret Kruk from Harvard T.H. Chan School of Public Health. And this morning in this session, we're going to talk about metrics. And just to put some context around the discussion, yesterday what we heard, of course, is that one of the challenges with public-private partnerships is coming to a shared vision. And that's particularly challenging when we have multiple partners, multiple stakeholders, all with their own motivations and reasons for engaging in these partnerships. And even on the corporate side, you have a lot depends on whether this is a philanthropic or CSR or a pure public-private partnership. The motivations and the metrics that are important may change. And then we also heard about different domains of measurement, or different domains of incentives, if you will, for engaging these partnerships, which include things like effectiveness, cost savings, efficiency, equity, efficiency. They're all different domains one can describe and place metrics in. And then, of course, the focus of this discussion the last 2 days is on health systems and the metrics that are used to measure the impact of interventions to improve and build health systems may or may not be the same as ones used for many vertical programs, and how to reconcile some of those issues as well. But ultimately, despite all these challenges, what we heard loud and clear from many people yesterday is that we have to find ways for shared vision and shared values to be defined, both at the beginning of public-private partnerships to get them moving, and then as those programs develop, some of those metrics may change. So today's discussion is about metrics and which metrics matter, and how to address some of these challenges as you establish public-private partnerships that are going to work. So what I've asked each of the panelists to do is just take a couple of minutes for some preliminary comments from their perspective on which metrics matter and on this general issue. I want this to be an interactive session, so we want engagement of the audience, and so I'll be pushing you to do that as well. But let's first hear from each of the panelists and from their own perspectives. We'll start with Sally.
Because she's conveniently located to the microphone. Yes. All right, so I'll try and say a few provocative things just to make sure that we have a jazzy discussion when we finish. Metrics. Oh dear, how can you be jazzy about metrics? They are a little boring, but those of us who live and breathe them love them very much. We did hear a bit from Rifat yesterday about effectiveness, efficiency, and equity, and responsiveness being metrics for the health system. Yes, indeed. I do think tracking those is very important to see if what we are doing has indeed strengthened health systems. But my abiding prejudice after years in this business is really what matters is outcomes. And the thing that will make people wake up, the thing that will make people commit resources and time and energy and partner productively is the hope of improving outcomes. So I would just make a little bit of a plea for that. There's another dimension of metrics that people talk about frequently, which is sort of the quality of the partnering process, which gets pretty muddy, as you might guess. The malaria community, with which I've worked recently on the Global Malaria Action Plan, the Action and Investment for Malaria report that is about to be launched, they've worked very hard on looking at the partnering process and trying to do metrics about that. But I will say there's not a lot of consensus about how to do that well. They've got some relatively creative things about making sure that partnerships indeed involve all of the key players and sectors, and that the balance between the public and private sector is appropriate to the task, but it's tough. It's out there, but it's tough. But I think one point I would like to make is that, information is one of the 6 building blocks of the health system. And those of us who believe in it, and I warned you about this, I'm one of them, really recognize that, you can't manage human resources if you're not tracking information about them. You can't manage supply chain if you don't have an information system. You can't do governance and policy if you don't have the data, the information about that. Services, are largely about information. So, and finance, even for me as a doctor, who's not very good with numbers, let's face it, if you don't have an information system, you really don't have a financial management system. So I think we need to recognize the sort of instrumentality of information in general, and all the things we talked about yesterday, whether you're trying to make an investment case to get partners to buy in, whether you're trying to share goals, what are they, what are the metrics for those, if you really want to document others' achievements and keep people jazzed about partnership, it's got to be evidence-driven. Momentum behind what we are trying to do has got to be about information and communication. And then the trust word that kept coming up yesterday is really about visibility and transparency in large part. So all about the data. One thing I would like to point out also about information is, somebody said, why is it so hard to do health? Well, I think information asymmetry, I understand from my economist friends, is something that characterizes the industry of health. So the buyers, the purchasers, the patients, the clients don't have as much information as those that are trying to sell stuff. And this leads to trouble. Now, the good news is that the trend is in the right direction. People are becoming much better purchasers, much smarter purchasers. But again, making sure that clients, that patients, that people are informed is what's going to make them healthy. So the knowledge to make good choices is very much about being well informed about what works. So, I do think that finally, to Devi Shetty's point, an informed customer is a healthy person. So the one thing that is, I think that characterizes this business as well, in a way I think public-private partnerships as a notion is going to come and go, because it's unthinkable to pursue health outcomes without working with the private sector. I mean, if you can't harness market forces and get them behind making health better and health interventions more sustainable, then nothing's going to stick. So I have, as a woman who's only recently joined the dark side, I will say I left the public sector and the philanthropic sector largely because I didn't think we were doing a good enough job of harnessing the engine of market forces to make things happen. So I'm excited that this group is assembled because I think you guys can help change that. And then just one story to finish, which I think shows, again, to somebody's point yesterday, it's not just the multinational corporations here. We need to harness market forces at the smallest and most peripheral levels. we had a little project in Malawi many years ago now, working with small, drug sellers in markets and people who were trying to move bed nets and contraceptives. And the remarkable thing was we were curious about getting feedback to communities about how they were doing. So embarrassing as it may be now, we actually randomized villages in the lower Shire Valley in the Chikwawan and Sanji areas, and gave all of these villages information about how well they were doing with regard to utilization and coverage with some of these life-saving maternal and child health services. And all of the villages got all of this information, the summary information. Half of the villages got information about how their own village was doing and how 5 other of their nearest neighbor villages were doing. And the fascinating thing to find was those villages that got locally disaggregated information about how they were doing and how their neighbors were doing, something happened. They were empowered. They realized it was intervenable, it was changeable, they could fix it. They took charge of their own health, and there was a nearly 50% increase in coverage and utilization in those villages that got the feedback, that got the information about them. And it was very powerful. So I think I would just make a plea that we understand the power of metrics, not just for our partnerships, not just for mobilizing resources for what we're trying to do, but also for people being empowered to take charge of their own health. Next victim.
Thank you, Sally, and thank you, Bob. Can you hear me in the back? Great. So it's a big honor for me to be here and to share a bit of what USAID is thinking now in terms of public-private partnerships and the overlay on health system strengthening. I know you're all eager to see Ariel Publis Mendes, but he's traveling at this point, so when you look at me, imagine someone tall, handsome, with a lot of Latino flair, and I'll try to match up to that. Yes, metrics are important to USAID, and all of you who've worked very closely with us know that we've invested so much, enough to bury ourselves in metrics, and also everyone else who partner with us. But then working through those into public-private partnerships, where for the last 10 years we had 1,000 flowers bloom in this area, and now we're taking a pause, taking a step back to look at where next we should venture. And so it comes back to metrics of how well have we really evaluated public-private partnerships. And a lot of the energy was on setting up the alliances and setting up the partnerships and working in the sector, but then did we measure enough of how beneficial it all was? And then on top of that, to look at how it has affected the health systems. Still a whole new body of work that we're learning within. And so going back to what kinds of metrics matter, of course, outcomes will continue to be important for us. Outcomes are also a proxy to let us know consumer satisfaction and also the reach of the population. But we are reviewing how meaningful have we looked at in terms of the kinds of outcomes we're measuring. Are they measurable? And did they really show the improvements, across the system? And so we would continue to look at these outcomes of effectiveness, efficiency, equity, but also we would bring on board other groups of metrics. And one of those include compliance. We have in public-private partnerships have set up standards and looked at regulations and whether you met them, you worked according to quality. I think Dr. Shetty talked about protocols and things like that. So a lot of measuring of whether you met those standards. Now we want to move toward, has it really improved value? Has it really given benefit to the population? Has it really improved the system? The other area is this area of contribution versus attribution. We work on public-private partnerships, and then we measure the outcomes, and then we assume that this was because of these interventions. And now we want to be a bit more purposive. We want to set up these partnerships in a way that it's addressing specific problems, have a good analytical framework that starts with baselines and looking at change over time. And one thing that we would try to be conscious of is that outcomes are outcomes that are different from huge impact and changes over time. Perhaps we should be more conscious of looking at near-time results that show the incremental changes and approaches towards reaching better impact. So looking at more of more periodic steps of progress over the timeline would be more important. But then we need to have flexible tools and systems that allow both public and private sector to be able to track those and track those jointly. So now, I'm glad Soji is here also. We just finished a huge conference on measurement, and particularly in preparation for the post-2015 agenda. So there's a huge push for evidence, especially when we're looking at investments in health systems and the improvement in health outcomes, and a lot of focus on results. And so in developing this contribution and incremental value, we're also cannot completely forget, although as Sally talks about the limitations of process metrics. If we were to continue working in public-private partnerships, we would need a few process metrics, but to be a bit more careful about what we're actually measuring within that process would be also relevant. And so, for example, some indicators we would try to focus on a bit more, and here we would, very much welcome your feedback, your input, your ideas. The issue of shared values and shared vision, how would you measure that? Is it a matter of looking at MOUs to see if everyone's agenda was captured and everyone's contribution was there, or are there better ways to show that a particular alliance had this shared value? In our experience with setting up PPPs, there's a lot of time lag on just setting up and then finally execution and then tracking the results of it. So the time taken from concept to completion, was that quick enough? Was that fast enough? Was it more efficient? And also, did the system allow both sides to equally access and use the information directly? So when we overlay all of that on the health system, of course we go through the outcome indicators, not just looking at how many people were reached, but also money that was leveraged, the partners that the alliance had brought on board, the numbers of population that were reached continue to be important, but we go a little bit deeper in looking at equity. Are we looking at the hard to reach, those who had fallen through the cracks? And that becomes a bigger challenge. Like, for instance, when I was working in the Asia Regional Mission, talking about drug-resistant malaria, and in a situation where in the Mekong region, the borders are porous and a lot of people cross borders to work in each other's countries, in a country like Thailand, which is the icon of universal health coverage systems in the region, there are almost 4 million migrant workers who are not accessing health services. And so when we look at a universal health care system, you think it's perfect, but then we need to identify who's been left out of this. And there's more complex, and the solutions are not necessarily technical. There's also a lot of political issues, and so it's calling for joint partnership between the champions, the reform champions, and the researchers, and also the program managers to come together in a more concerted fashion. The other dimension that I would like to throw out is we use, PPPs in order to strengthen the health system, but to be a bit more discerning in terms of whether we are strengthening the health system or we're extending it. So, working through contractual ways, working with private sectors, social franchising, and extending services to areas that you were not able to reach is straightforward. But then was the system strengthened from that? What do we need to put into place so that it's not just expanding availability, but the system is able to be sustained in the future? I'd just like to, and then, we talked about vertical programs, and they do work on health systems and they do strengthen it. When we look at drug-resistant malaria in the border areas of Cambodia, it actually happened in areas where the health system failed. But then we look at distributing bed nets or extending treatment or whatever, but in parallel, we also need to strengthen the health system. And so have we really looked at the ecosystem in totality? We are correcting parts, bits and pieces of the ecosystem, but how will we bring it back so that the sector itself benefit? And here it calls for a lot of dialogue between the national programs, between external donors, between technical assistance, between private sector, with the core functions of government, between the finance and between the policymakers to come and work together. So I just want to wrap up that with a few threads that USAID is tracking in preparation of the post-2015 agenda. And that in the field of health system strengthening, of course, we continue to do all we do in the 6 building blocks, but there are a few areas that we would give a bigger focus, and one of them is domestic resource mobilization. And so looking at in the post-2015 agenda, it's no longer the kind of financing. We are on the verge of, a few blocks from here, the negotiations for the Financing for Development conference is going on. And so we're looking at a new era of financing where it's not just donors and recipient countries, but a partnership, a catalytical framework that would also mobilize resources. And within that, it's not just the traditional way of working through revenue generation and looking at taxation and looking at increasing the fiscal space for health, but also working through innovative financing mechanisms. So in those innovative strategies, private sector does play a role, and therefore, what kinds of metrics would we need to see? A lot of these financing strategies are still new. Even in the health sector, there's not a lot of evidence, so we need to track those to see, for instance, like development impact bonds. We don't really have those in terms of a good body of evidence in the health sector, but we may be experimenting with those, and therefore we need to be very thoughtful with metrics around that. The other thread, of course, is continuing to be important is human resources. And here again, working at things like National Health Workforce Account, where we track not just public but private sector human resources and also empowering them. And so on that front, I'm glad Sally brought up the issue of field staff, field providers. And here, sometimes the metrics can take over their ability to really be smart and capable. It talked about smart technology, but how can we use that technology to make people smarter? And so here is the balance. In the measurement conference, it came out that definitely there is a tension of how much you want to measure, what you want to measure, versus how much you want to use them. And so building that culture of data use, so that's the third thread, is the data revolution that we're facing. So on that front, yes, I agree with Dr. Shetty. Information technology is so important. Right now, we're also facing the biggest data breach in the US government. And so with all of that overlay, we need to think through. For years, we've worked in the HIV sector to make sure that confidentiality, patients' dignity are ensured. And so here, how can we ensure that as well? So the last point that I want to bring up is also to brainstorm with you all and also learn of this issue of health systems resilience. And so the Ebola experience had really taught us that health systems can crash when a huge shock happens. And so looking at ways of, are there ways to preempt that? In the banking sector, you would have heard in the European banking sector we applied stress tests to find out if the banking sector would stand up to these huge economic crises. And so what kind of adaptations can we do in the health sector so that it's not after the fact that we know that a system was not resilient, but to have markers, to think ahead of how we can. And here, in the Ebola crisis, when the health system crashed, we had to rely on who else was there, not just the private formal, but also in the informal sector, to see how we can reorganize those resources. But also, I'm glad to hear Dr. Shetty talked about empowering the patient, empowering the family. And so can we get information out there where families are also able to take charge when nothing else is available? So with these 4 issues, I'd like to take a pause and then continue later.
Thank you, Bob. Can everybody hear me in this microphone too? Okay, so thank you. My name is Justin Custer, and I'm with Medtronic. For those of you, I think it will be helpful to provide a little bit of context. Medtronic is the world's largest medical technology company. So our key piece of contribution to health for 60 years has been things like surgical implantable medical devices like the pacemaker. And so I think not to focus on the technology, but to focus on our mentality as a company, I think is very important in the context of why we engage in public-private partnerships and why we are interested in the healthcare system. And so to take the example of the pacemaker, it's been changing and evolving just like a smartphone, if not maybe a little bit slower, for the past 60 years. So there's several companies globally that make them, and we're just one of them. So I'm not an engineer. I don't claim to, and I'm from government affairs for Medtronic. So my job is not to sell you our pacemaker over the next one. My job is to try and convince governments to buy more pacemakers overall. And so with that in mind, we're trying to engage governments to work, and I think I don't know how many of you have been reading or have heard from Dr. Devi Shetty before, but the amount of energy and effort and just the incredible stories that he's able to tell is the same reason that I think Medtronic is engaged in these types of partnerships, is that fundamentally, in order for us to improve and for our pacemakers to evolve, we need to get to greater scale in the healthcare system. And so I think, just from personally, his efforts are just incredibly inspiring. So with that context being said, I think measurement in the terms of public-private partnerships, and I'll be very brief. I could give and go into examples into Q&A. Medtronic is engaged in a few public-private partnerships in a sense, but I'll skip the examples for now. But so our important philosophy or important emphasis is Medtronic really believes in putting the patient at the center. Every single global town hall that Medtronic has, our CEO puts on the board how many patients Medtronic's lives has touched. And so for the last couple of years, our metric has been going from every 5 seconds to 3, then 2, and then via an acquisition, a Medtronic device actually interacts with the patient every 0.2 seconds at the moment. So with that many patients touching Medtronic products, the most other fundamental part of our devices, like a pacemaker, is that we're very focused on the outcomes of the patient. And so a lot of the ways that systems are measured today is only from a single point in time. So from our perspective, expanding that temporal frame, like both Dr. Devi Shetty and Sally and I have already mentioned, is again fundamental to Medtronic. And so we're completely aligned in that thought, because if our pacemaker doesn't keep that person out of the hospital, if that pacemaker does not prevent or reduce the future complications of heart failure, et cetera. We're not making a good pacemaker, and someone else needs to make a better one. The other aspect is patient satisfaction. Same thing. Do they have a good experience with our device? Our device is throwing off a lot of information. Our patient counselor is able to help them in a quick and effective way. And then the other angle for complicated surgeries and for tertiary care is what's the impact on the family or the caregiver, and what's the burden on them as a result of that surgery or that intervention. Another way Medtronic is engaging in partnerships with hospitals and with governments is through improving infrastructure and improving the utilization of existing infrastructure. So again, we're a company full of engineers. We have Lean Sigma black belts. I think we have over 15,000 engineers globally. So we're really good at improving the quality of our own devices. But then when we look at our partners and that they were delivering our devices, to be frank, they were very inconsistent and inefficient. So today, Medtronic is developing a business model around improving cardiac surgery and cardiac cath lab efficiency, and also surgical and operating room efficiency. So to give one example, in a very world-renowned hospital in the Netherlands, we have been able to take engineers on a temporary basis, on a consulting basis, and reduce the time of diagnosis from the moment that a patient enters to the time that they are, appropriately diagnosed, from about 2 weeks down to 24 to 48 hours, and that's in about 6 months. And so, we've done, lots of measurement in terms of calculating all that. But again, that's just a bunch of engineers going in and shifting the seats and shifting the protocols in a hospital to raise it to what we have seen as best practice globally. There's, again, lots of different ways to measure that impact as well. And then I think the other important note that's complementing my first point about the temporal nature and the importance of expanding that notion is measurement needs to occur and will benefit medical technology disproportionately if we expand the scope of that time at different levels of the healthcare system. So whether that's primary care, secondary care, tertiary care, whether that's pre-hospital, in-hospital, or post-hospital, and then also at every level of extraction at the health system. So whether that's from the health facilities perspective, the payer's perspective, or the overall health system's perspective. And then I just would like to reiterate and maybe put my spin on Sally's point about transparency. And I think again, referring to Dr. Devi Shetty's presentation, I think the most important thing in transparency is two-way transparency. So when both sides and it addresses the asymmetric information question as well, but I think the example coming from Dr. Devi Shetty of each of the physicians in the hospital getting a daily P&L and being held accountable for that should, change your paradigm of thinking of what is possible. So thank you.
Good morning, everyone. I'm Kathy Taylor from the University of Notre Dame Eck Institute for Global Health. This has been really just a fascinating meeting today in the panel, and I'm very humbled by the scope of the projects that we are hearing about, and the impact. And I just want to bring a little bit of the university perspective, firstly, and then secondly, to talk a little bit more about the meeting that I alluded to a couple weeks ago in Washington on measurement and accountability. So the university perspective, we haven't talked really at all about research. And most of what we do is research and training, and I think measurement around research tends to look quite different than measurement around impact evaluation of specific implementation programs. So it has specific needs. I'm not going to go into a long discussion of what those are, but just to table the fact that they exist, and in partnerships, those research questions that might be embedded in the partnership may take on a whole other set of resources and needs in terms of data collection and evaluation than some of the partners are typically accustomed to. The reporting might be different, data collection, program design, what impacts and what outcomes you measure, and the time frames. So I just wanted to put that on the table as something that the group really hasn't addressed in terms of the essentiality of the research and leading to new solutions. We talk a lot about technology and innovation, but they have to be proven, and there's only one way to prove them, and that's through research. So I want to make sure that that gets tabled. Then I also want to take a minute to talk about now what we're doing now, but where I think we're going. And this meeting in Washington 2 weeks ago that was sponsored by USAID and World Bank and WHO, I thought was fascinating, and I was very heartened by it. And I urge you all to go to the internet and find some more information on this particular report. It's called the Roadmap for Health Measurement and Accountability, the 5-point call to action. If I had more time, I would read the 5 points to you, but I'm going to spare you, and I'm just going to tell you what I kind of think is a few important points that also are building on some points that have been made earlier in this meeting. So the 5-point call to action, the goal is to construct a common agenda to improve and sustain country measurement and accountability systems for health results in the post-2015 era. So it will be tied to the Sustainable Development Goals. The roadmap aims to ensure that countries have the necessary information and capacity to plan, manage, and measure their health programs, as well as monitor and achieve their national health goals and the health-related Sustainable Development Goals. And I think for me, what I took away from the meeting, and because of all of the low-income Ministry of Health representatives and high-level people from those governments that attended the meeting and were able to express kind of where they're coming from, is the principle that the ownership for what data gets collected, how the data is analyzed, who has access to the data, use of the data to drive decisions, it must reside at the country level. And I think this is something that's really going to change the nature of some of our public-private partnerships and all partnerships in general, that the country-level decision makers at this meeting echoed the importance of this ownership residing at the country level. Questions about who is the data for, how will the data be used, what resources will be required to collect, store, share, and analyze the data. Because resources are spent in collecting the data, there has to be a value chain associated with the collection, storage, sharing, and analysis, et cetera. And the whole value chain has to serve the health needs of the country. And often they're just serving the data needs of the partners. Not that those are not important, but our primary goal has to be the health needs of the countries and the communities. We also have talked a lot about the proliferation of global health organizations over the last 10 years, and they have both driven the dramatic advances that we've seen in health in many low-income countries, primarily through implementation of vertical programs, and we've talked about how the evaluation and data collection for the vertical programs is a little bit different. But these large number of health organizations have also driven the complexity of the donor environment and expectations. And a speaker yesterday recounted how a new minister of health in a low-income country was sort of lamenting, all I do is organize donors, you know. I mean, and that is a problem. So donors and partners have driven demands for more indicators, often with less transparency on the purpose of the indicators, plans to share the data, and who's really going to benefit from the data. And I've observed this one-way flow of data. You know, you're in a community health center and you see there's one little room and they have the stacks of forms that need to be filled in for every project, for every donor, for the ministry, and resources are used to complete those forms, and they go in on a monthly basis and nothing ever comes back, and that's really the challenge that we're facing. And so it's just as was pointed out, that information then is not there to make decisions about the health system. So I think that there is a drive to push the ownership of these responsibilities to the country level, and I support that drive, and it's going to be an interesting change in the paradigm over the next few years. So, thank you.
Let's see if we can do this without knocking any drinks, hurting anyone. Good morning still, yes. Hi, everyone. I'm Margaret Crook from the Harvard Chan School of Public Health. And thank you so much, Bob and others, for having me on this panel. What an important discussion. I think that I've been struck during my academic career, and I really see a trajectory upward and forward on the role of public-private partnerships in enhancing the value that we can bring to patients and people globally in health systems. And so what I wanted to reflect on in my brief remarks was sort of what are the new perspectives that PPPs can bring to the delivery of healthcare, the functioning of health systems, and the promotion of global health goals. What's new and different? So I would suggest there are three broad areas where private partners bring a perspective that we haven't, that we can really benefit from globally. And I should maybe take an aside here and explain that much of my work, most of my primary data work is actually in sub-Saharan Africa. And yet I'm seeing where people are, living on a few dollars a day, where health systems are spending $30 or $40 a day, not per year, not $8,000 per year like our system. And yet where private partners are able to shift the way that we think about patients, and how that's also meeting with where patients are evolving toward. So I think the first area that I've seen in my experience is the customer-first focus. This is not something global health is famous for. We have been very focused on getting people to facilities at all costs. We pay them, we pay the health workers, we do all sorts of things to get people into facilities. But where I think the private sector is more interested in is what happens when they get there. What's the patient experience? What's the customer experience? Now, I think that one difference I've noted, having worked with both government partners and private partners, is, I think government partners think a patient experience is a nice to have, and the private sector knows it's a must have. It's the basis of trust. It's the basis of adherence, right, and continuity, all those things we speak about and yet don't really know how to act on. And I think that that perspective is vitally important as populations in even the lowest income countries are now facing chronic diseases as the primary burden contribution. HIV is a terrific example of a chronic communicable disease. Of course, there are many chronic non-communicable diseases that are on the rise. So the idea of having loyalty and having faith and trust throughout for the long term is something the private sector knows all about, spends a lot of money developing and researching, and can really bring to public health care delivery. Related to that, I was interested in this distinction that we sometimes make between outcomes and the patient experience. I think both are important. I think I just made the case for why patient experience is important. By the way, all of the talk about universal health coverage relies on a fundamental assumption that patients will support greater spending on healthcare and will support prepayment and will support the purchase of insurance. Look at our Affordable Care Act discussions here in this country. And again, patient support doesn't happen in a vacuum. It happens in the context of a system people want to use. So again, trust and patient satisfaction are not side effects. They're one of the main jobs of the system, health system. But in addition to patient experience, I want to say a word about outcomes. I think outcomes are crucially important. Healthcare has to demonstrate value by lengthening lives, improving quality of life, reducing morbidity. All of that's absolutely critical. And I just want to say, though, that increasingly, as people live longer and as we're getting toward better and better longevity, the patient's own sense of their health, which is based on patient-reported outcomes. The global assessment of health also matters. Just a small example, you're all familiar with the very rigorous, very good work, I think, assessing some of the insurance initiatives in this country, including the Oregon Health Study, which famously published that despite lots of insurance being Medicaid insurance being provided, Hemoglobin A1C levels didn't improve necessarily. A lot of things didn't improve, but what was notable to me is what did improve. Depression scores improved. Patients' own assessed health improved. And I'm reminded of my years as a family physician in northern Canada many, many years ago, in which there was a sense of trust and security when the health system is working and when insurance is provided. And I think measuring the patient sense of their own health is an equally important outcome once we start reducing the hard outcomes. One other thing in this sort of bucket of responsiveness that I think public-private partnerships can teach us is to look at the process. Again, we've heard some great examples already on this panel of being able to take apart the process, open the black box, and say, how do we reduce times, wait times? How do we improve queuing and strategies? How do we reduce diagnosis delays? Those are going to be the next frontier of challenges once we get people into healthcare. And I would posit here, and I know it's a little ambitious, that we've largely solved the utilization problem. We haven't solved it today, but we have the tools, and we can demonstrate huge gains in getting people to healthcare. And now they're going to hold us accountable for what happens when they get there. And that's where the process measures and understanding of process of care delivery, which I think, again, the private sector can help us with, is so important. Second area that I've personally experienced in working in evaluating PPPs is what I love is the skepticism and almost the ruthlessness that private sector permits us in when we're looking at our own results and effects. A few of the folks on this panel talked about the importance of evaluation, and that, by the way, monitoring is not the same as evaluation. They're always lumped together. But evaluation means, can we demonstrate benefit from a new idea, right? New product or new service or a new way of arranging services. And having worked on a recent, in evaluating a recent very large public-private partnership, it was striking to me how in leadership discussions, the kind of faith in the program was much stronger on the public side, and there's much more skepticism and willingness to abandon the thing if it didn't work on the private side. And I frankly think that sort of ability to just cut this thing off if it's not delivering is something that we in global public health really can learn from, because we often chase our own pet ideas for far too long and actually end up replicating failed solutions far too often, and something the private sector I don't think does nearly as poorly as we do. And the last area in which PPPs I think can teach us something is the desire for parsimony and transparency. There's a lot of impatience in private partner boardrooms with, flourishing and massive lists of indicators. Indicators have to earn their keep. Metrics are expensive to collect. And so they better demonstrate value, just like anything else we do in healthcare and any other investment we make. Measurement systems, I couldn't agree. And Dr. Stensfield is a pioneer and a massive advocate in this area. And I couldn't agree that information is extremely exciting and very jazzy. But what information and how much of it and who gets to use it? And so reporting up, absolutely important. Comparing, against among countries, among regions, generates important peer pressures and very positive effects. But if the information doesn't come back down in a readily useful form, and a number of folks have pointed this out, its utility will be limited. And if we should be thinking about cost effectiveness of collecting all those metrics. And I, just met with my team and reviewed a 200-question survey that we're about to field in Tanzania. So, we're equally as guilty. But I will say to you right now, with every question we asked, how will we evaluate this? Will we analyze this question? And if not, let's drop it. And I think that's the kind of mentality that PPPs help us bring. And just a final point, and I'm heartened by the fact that I just learned at the Metrics Conference in DC that there is a 100-indicator project underway to try to wean down this massive list of things that we all care about into something much more tractable. And then let me just come back to the patient, which is where I started my comments, and which has already come up a number of times. People demand information and will increasingly demand information. So when we're thinking about the metrics loop, yes, we need to collect patient-level information, but then it has to come back to the patient. not just their own information, but the aggregate information about the performance of their local health system, how their doctor's doing, is he or she accredited, is he or she should he or she be doing heart surgery on me? These are the kinds of things people need to know. And not only do they need to know in some normative sense, they're demanding to know it. We are showing in our work in Tanzania that women who have a cell phone and who listen to radio or TV more are increasingly bypassing their local health facility to find a hospital, and they're reporting better care there. They are not waiting around. This is not a Manhattan consumer, let me just assure you. This is often an illiterate, 50% literacy rate person with very modest wealth to be able to do this. And yet they're doing it. They are acting on the information they get to seek better health care, a desire that is a global desire in the health system, both here and in lower income countries. Thanks.
Thanks very much. That was excellent from all the panelists. Let's open up and see what questions we have from the audience. Joe.
I'm the warm-up asker while people were thinking. I want to specifically ask Sally this question from her earlier lives on the International Health Metrics Project, because all this is well and good, but I think what we're seeing with the SDG metrics process and various others, the rate-limiting step is often what capacity exists at local and country level to gather the information in the first place. So, there's vital statistics are pretty good, but after that it's highly variable. And I know you spent many years talking with health ministries and other ministries about this capacity building issue. So I wonder if you could comment on where you think that's come in the last decade or more. And then secondly, we've talked about one of the dangers, I think, when you set up metric systems is that you're measuring what you know now. And you sort of collect things that may or may not be relevant to the future. And I'd just be interested in everybody's kind of comment on that, because now with all this modeling that's going on, I'm seeing people modeling what's been happening for the last 5 years without being able to account for all the things that might change. So I just sort of one question for Sally on capacity and the other question for others on sort of system change versus, sort of is our metrics, what we asked to measure, going to keep things the way they are?
Yeah, well, I confess I would love to talk about that for hours, but it would require a meal and a bottle of wine, I think. But a couple of brief comments. I think there's been fabulous progress in country ownership of information systems and the facts. I mean, part of it is enhanced by the fact that there are now tools that help with district health management, and now there are open source software packages that DHIS2 and the like, which can really make the information readily digitized and accessible and useful and used. And people are getting really much smarter about how to benchmark progress, a bit like the P&L daily reports, so that you can have more accountability and rewards for good, effective behavior locally. So I think it's changed a lot, and I think also, we've heard several references to the with the post-2015 agenda, the growing focus on domestic resource mobilization instead of continually relying on donor funding. And, I think, as is evidenced by this recent conference in Washington, the donors now get it that they don't own the data. That it's if folks in countries are not owning their facts, they are not owning the problems, they are not owning the accountability to deliver solutions, and they're not owning the credit for changing outcomes. So that has to be information driven. So that I think that it looks good. And the other thing, your other point, which I think is really very interesting, one of our big problems with the global architecture in health is that it is the funding channels tend to drive and shape what we measure. So I think, to your point, as you suggested, one of the big problems we have with information in health is that we collect information about diseases. Our Centers for Disease Control in the United Snakes, bless it, is everyone has a vanity surveillance program for their favorite disease. We're not doing public health surveillance, we're doing disease surveillance. So if there's a new disease, we're not going to find it. Because, we're not doing surveillance for, as we learned with Ebola, we're not doing surveillance for unexplained clusters of deaths. We're not doing surveillance for things that we're not expecting to find. I think hopefully we can change that too, but I would very much welcome a transition away from disease surveillance and towards, and project-driven data collection to real, comprehensive, country-owned health information.
Would anyone else like to address the other question, Joe's? Any other comments? Patrick?
Thank you. There were a variety of things that came up that I just would value you commenting on. One of them got back to the comment by Dr. Shetty's about the profit and loss being reported on a daily basis. And I wonder, that kind of surprised me. I'm sure somebody who cares about profit and loss. But it seems like they use metrics not only to help manage, but also to help motivate. And Sally, you referred to the data that was generated in the villages and how when you have not only data on your village, but other villages, that can be used to motivate. So I think one issue around metrics that's important is not only having the metric, but having it at the right time and giving it to the right people to achieve the change that you're looking for. A metric all by itself is only a bit of information, not a bit of motivation. And also the emphasis on country ownership, I appreciate where that's coming from. I sometimes wonder, though, whether you want even more than country ownership, but ownership by the patient, as it was alluded, ownership by the community. When you're running a big program, I suppose country ownership is a natural descriptor to use, but should metrics be characterized by the need of the user to use it to institute change, and those users could be national managers, but also local managers and patients themselves. So I guess I was just thinking about all the dimensions of this, the timing of the data. Is it coming at the right time, and is it going to the right people, all the right people?
Sure. I think that's an excellent point. And I think ties into the notion of usefulness. For any enterprise to be sustained, particularly an enterprise that's somewhat tedious, with apologies to Sally, and expensive, and it does have to justify its existence. And I think your point about not only do we want to identify the right metrics, small set or some manageable set, but also the right users of those metrics. And I think I would add just the timeliness for communicating back, the post-mortem term stuck in my head that Dr. Shetty used. That's what we're largely in the business of in global health, unfortunately, looking at things that happened 5 or 10 years ago. Maternal mortality is a classic example. We need 10 years of data to be able to say something. So I think timeliness and identifying the user group, I would just add to the broader issue of, is this really a cost-effective metrics system? Is it reaching the right people on time? And is it the smallest set of data that we need to create change?
So let's do this in the last 3 minutes. We'll take the last two questions for the panel, and then I'm going to ask each of them to give us a 10-second priority list of metrics. But let's hear from John and, I'm sorry, Kate. Paul.
Thank you. I remember when I was the Deputy U.S. Global AIDS Coordinator at the beginning of PEPFAR, how CDC had its own reporting mechanisms for HIV/AIDS. USAID had its own reporting mechanisms for HIV/AIDS, and then PEPFAR came along to create a third reporting mechanism. You've made a lot of good points about the fundamental importance of metrics earning their keep, and because they're expensive to collect. But given the effort that's going on globally to have, whether it's 100 indicators or however many it comes out to be, and the effort to really have indicators that would represent a broader spectrum than just the indicator itself, what is being done within governments? Is the European Commission, is PEPFAR, is USAID and CDC, are they going to go along with this, or are they going to continue to have their own separate long list of indicators and metrics that will end up putting even so that this whole effort will actually put more burdens on the countries who are receiving the assistance?
Thanks. Paul?
Yes, Paul Mikov, Vice President for Institutional Partnerships at CMMB, which is a global health organization. I'm delighted that quite a bit of our conversation on this panel has been around metrics, evidence, measuring, etc. Perhaps a game-changing element and presumably a significant impetus to public-private partnerships ever growing, ever more numerous, and ever more effective, happening in particular at the national and the local levels where the rubber really meets the road, would be the ability to demonstrate and showcase what I would call cumulative effect, where the whole is greater than its constituent parts. The ability to demonstrate that if, say, 5 partnering organizations somewhere in Africa, bringing together joint resources of, say, $10 million, pursuing common agreed objectives over a certain time interval, could actually demonstrate 3 years down the road, for example, that their $10 million investment, joint investment, resulted in terms of better health, reduction of morbidity, mortality, or stuff like that, in economic terms, somewhere in the vicinity of $20 million in the lives of women and mothers and children. So this notion of cumulative effect, that there would be consequence and effect as a result of our genuine partnering together that otherwise would not have been there. I wonder if some of you, especially those of you coming from some of the best academic institutions in the world, could reflect a little bit on that. What could we do about that? Because the rhetoric and the theory is absolutely compelling. We are all for it. But the national and the local levels, unless we are able to demonstrate that coming together does result in cumulative effect, in something that is greater than what each of us would have been able to accomplish on our own, those partnerships will not necessarily be as they ought to be.
Thanks, Paul. So I'm going to ask Ai if she'd like to address John's question. Is the government going to buy into these indicators?
I wish I had a clear and concise and thoughtful answer to that, but I would say there are a lot of efforts. I think the roadmap is one of the ways that we wanted to table how we can streamline at the country level and have countries lead the information collection and use process. Connected to that is also what we have learned through the PPPs metrics in the past is there was a lot of information, but that information was good enough to measure accountability, but not good enough to learn. And so we're also moving into a new body of information collection where the information is helping people to see how to design their programs in better ways to adjust, to modify. And so part of that is also documenting failures. So there's an active movement in USAID to start documenting interventions that were failures, that were not successful. And we all said, yes, we certainly support it, not that it has anything to do with me, but I'll help with the system. And so that was just a joke, but definitely. And we do have some of these examples, like in, this is moving away from HIV, but into the time we had the avian influenza epidemic in Southeast Asia. And we were looking at whether the mobile technology interventions came up. And so everybody wanted to use mobile phones for every purpose. And one of those things were to monitor the price of poultry. And if prices fell, the hypothesis was probably there are poultry die-offs, and probably there could be epidemics. And so even though the technology worked in bringing back the information, the hypothesis of prices, the level of prices against outbreaks were not really connecting. I mean, it didn't really prove that you could monitor poultry die-offs. So that saved us a lot of money on not scaling it beyond one area that we sort of played with. Is that?
Yeah. We're over by 3 minutes into the coffee break, I think. I want to keep my eye on the time. So real quick, Kathy, how about
Bob, we started a little late, so take a little
Sure.
bit more time. Give people
So Kathy,
a chance
why don't you address the other question about cumulative effect and whether we can get multiple partners and multiple programs to share both the credit for things that work and the responsibility for things that don't work.
Well, I think we have to have faith in mankind here a little bit. But I see is our colleague from Bangladesh still here? Yes. And I know when I was at the meeting 2 weeks ago, I heard the story of the successes in Bangladesh that were linked to actually a very large investment over the last, I don't know, you can probably speak to this better, so I don't want to be the expert in the room with you here, but a very large investment in health systems, data management, frameworks that are completely interoperable. It seemed in some ways to be much better designed than our American system, which is kind of a patchwork quilt of all kinds of things. So if I go to the doctor, my medical record isn't available to anyone else. So I think that we already have some examples of success and what it takes to get there. And so from a sort of scholarly academic point of view, I believe that there's probably a lot of information to work from, and that exists. So, but I would welcome anybody else's thoughts on that.
So let's do this just before the coffee break. I'm going to put a little pressure on everybody. 10 seconds. We'll start down that, and just give us your top 2 or 3, in light of what you've heard, if you could give us your top 2 or 3 most important metrics for public-private partnerships focused on health system strengthening. We'll start with Margaret. We'll end up with Sally, because I'm sure she never gets the last word in any other. But go ahead, Margaret.
So I think the patient's rating of quality, patient view of quality, has been linked to in lit reviews and work to better outcomes, adherence, retention in the health systems. I would start there. And then, I think sustainability of a program, the ability of it to sustain itself and adapt. So that's not a metric, and that's a category of metrics. It's not something we mentioned, and I think again, PPPs are exceptionally good at understanding how to stay in the market.
So I think I have to really agree with that. I don't have anything much different to offer. I think we are at the point of it's really about the quality of the health care and the quality of the experience, and measuring then that back to the community level, and really the health of those populations and their satisfaction with how they receive their health care services, how they're financed, and how they participate in their health care.
So I will also reiterate the patient centricity. I would also repeat my thought about the notion of expanding the time frame and expanding the angle of measurement. I think we are in, because of the two major forces that Sally spoke of about market forces and health IT and information transparency, we are at the very bleeding, front edge of new angles of measurement. So measurement across the different angles of the healthcare system at all levels.
One point, Miss. My name is AA.
Oh, I'm sorry.
It's okay. Three key messages. One is people mentioned the consumer as part of the partnership, and I would bring in this issue of, we do a lot of market surveys, we do a lot of feedback, but have we reached the stage where the consumer is actually a partner? I was, when we were looking at these, how to improve migrant health care, I had to go back and look at the U.S. Legislation on Migrant Farm Workers Act. And here it says the migrant health care centers that have been set up, the migrant workers themselves should represent the majority in the board. So they were over 50% representation. So when do we reach that part, and how can we empower that? The other area is when we look at continuing these partnerships, our approach now is to do fewer but better quality partnerships. And in that situation, we also want to be clear about which problem we're really trying to address. And so in the past, we want to strengthen the health system, we want to extend services, but now we need to look at what are the things that are really wrong, and how can you really measure and address, and whether it has really changed. And so one of the examples was in Cambodia, as we were rebuilding the health system, we had to acknowledge that there were rent-seeking behavior that was distorting price systems, and the public sector themselves were behaving in a private way with no regulation, and therefore you need to develop this health financing charter where people were paid on the basis of what they actually delivered, and that needed an information system that really tracked their contribution. And so, I think at this point, and looking back at the West Africa Ebola countries, now that we're rebuilding health systems in there, we need to, other than reviving the services, we need to look at what was wrong in the past and how do we directly address that. The last point was, I'm glad people brought up this issue of sustainability. We do look at creative ways of addressing whether a system has or an activity was sustainable. And one thing I learned was from the German Development Bank, KfW. When they used to have projects, they would go back to assess, after the project has ended, 2 years afterward, they go back and assess what has happened based on what they had contributed. So sometimes we sort of work through impact evaluations, end of project evaluations. We do all of those, but do we ever go back at the end to see what was left after the presence was removed? So there's 3 points.
Thank you.
All right, I'll do 2 deeply oversimplified ideas, agreeing with the previous speakers about priorities. One, I would say, is that we need to make sure that we balance the dynamic tension between privacy and the huge benefit to public health of and quality of care of sharing, and make sure that we don't reward people for hiding behind privacy, confidentiality, security as a smokescreen for protecting their own revenue streams. To be mean for a minute. And then I think the second big thing is, there's lots of money for analytics at the global level. We all do it for a living, but there's very little investment in country level and peripheral analytics. So I think there's a huge opportunity for public-private partnerships as they get out to national and subnational levels for those forces to invest in analytics to make investment cases for what the highest health priorities are in countries.
So thank you. So it's going to be a challenge to summarize all this, but I'll say that it was a great discussion. I did hear a consensus that the ideal public-private partnership should focus on outcomes that matter to the community, to the patients. That would be the ideal program. Now, of course, as H.L. Mencken said, an idealist is someone who believes that because a rose smells better than a cabbage, it'll also make better soup. So it's all in the definitions of what those outcomes are. And I think Gina yesterday reminded us that while we may all agree that community outcomes matter, health outcomes matter, everybody has to come to the same definitions of what those really mean in order to move forward. We also heard a lot of great discussion about the various metrics that matter from different stakeholders, and we'll capture that in the report. Let me just take a moment to thank the panelists, Sally, AA, Justin, Kathy, and Margaret for their great participation, and we'll take a break for coffee.